Hello and welcome to this talk on bedwetting. My name is Jòh-Ann, and I'm a physiotherapist originally from South Africa. I qualified in 2011 from the University of Pretoria and has been working as a physiotherapist since then. We moved over to New Zealand in 2022, and here I work in a little clinic in Nongatawa. I'm seeing people with musculoskeletal problems, so pain and injuries, as well as people with pelvic health problems. Now, in pelvic health, I see both adults, so men and women with bowel, bladder, and sexual dysfunction, as well as children with bowel and bladder dysfunction. My social media is divided into kids and adults. So for kids, I can be found at Kids on the Loo on Instagram. And for adults, you can find me at Jòhs, Gouws, physio. And if you have any questions after the talk, you can email me at jhouse, Gouws, physio@gmail.com. So we'll jump straight into it to discuss what is bedwetting. So bedwetting is defined as the involuntary loss of urine during sleeping hours. The medical term to communicate bedwetting is called nocturnal enuresis. So nocturnal, a lot of you will recognize from nocturnal animals, which means nighttime, and enuresis refers to involuntary loss of urination. So the term involuntary refers to being out of your control, meaning that people who have involuntary loss of urine is not in control of being able to urinate. So when we're talking about bedwetting in kids, we always want to know what is considered normal or abnormal, or when can it be diagnosed. Now, I don't like using the terms normal or abnormal because there's a variety of what is normal. But in terms of when we can diagnose bedwetting, we are looking at a diagnosis after the age of 5. So before the age of 5, it's not considered something that's a problem necessarily, or something that we should be treating as a diagnosis. There's two types of bedwetting that a child can have. So primary bedwetting refers to a child that has never been dry during sleeping hours. So they've always woken up with wet nappies or wet underwear or wet sheets and things. And then secondary bedwetting or enuresis is when a child has been dry for at least a period of 6 months. So it might happen that they were dry for a year or so, and then all of a sudden they start having bedwetting episodes after that period. So that would be referred to as secondary bedwetting. So if we're looking at what the expected development in children are, we want daytime continence. So usually during the daytime, children will be dry first, and somewhere around 10 months after being dry during the day, they will develop nighttime dryness. So that's more or less the expected development. Of course, things don't always go as expected. Most children will achieve daytime dryness between the ages of 2 and 3. So if you're looking at then 10 months after them being dry, that would be before the age of 4. And even though that's the expected development, we still see in our guidelines and things that we can only treat it as a problem or a diagnosis after the age of 5. Sometimes, however, this process can be delayed a little bit. So in children who were born prematurely, in our neurodivergent children, so ones who have autism or ADHD or other things that can impact their neurodevelopmental functions, they can have delays and achieve these types of things much later. And a lot of the times we would expect that to be considered normal in those cases. So if we're looking at what causes bedwetting, there's a variety of things that can actually contribute to bedwetting. And it's not one simple answer of just using a specific alarm or stop stop them from drinking 2 hours before bedtime, that usually is the only solution. So there are certain things that need to be ruled out, like type 1 diabetes. Now, in most children with type 1 diabetes, they will have other symptoms like fatigue and a dry mouth and changes in their appetite. But in some children, bedwetting can be the only sign. So, if that has not been ruled out, that is something that a GP should ideally look at and rule out as a first line test. Then, things like sleep apnea can also have an effect. So, with sleep apnea, it refers to a child that's not going through their normal sleep cycles, and they actually can have a bit of problem breathing and then wake up or not ever go into their deep sleep cycles. And that would affect their hormone production. So, in normal cases, people produce a hormone called antidiuretic hormone, and that helps us to produce less urine during the night so that we don't have to wake up and go to the toilet to empty our bladders as often as we need to during the day. Now, if we're not sleeping properly, we can make less of that hormone, and our body won't respond to, or our body will respond to the levels of hormone available. So what will happen is they will continue making their normal volumes of urine, and that will obviously fill the bladder, and they will need to go and urinate more. Now, for some people, that's not affected by sleep necessarily, but their body just doesn't make enough of their antidiuretic hormone, or their body does not respond appropriate to their levels of antidiuretic hormone. For some kids, it will also be a sleep arousal problem where they're not actually waking up from their body's signals coming through, and then they will end up wetting the bed because they're just not responding or not getting that signaling that they need to actually tell them that it's time to go and urinate. And that sometimes happens with sleep apnea as well. In some cases, we do see infections causing bedwetting, but that will mostly be in cases where it's secondary bedwetting. So if your child has been dry and then all of a sudden, out of nowhere, starts having bedwetting episodes. For some children, it will be related to sleepwalking problems. And in a lot of those cases, children will get up out of bed but still be asleep and walk elsewhere and then think that they are in the toilet and then wet the carpet, for example. And then something that's not a direct cause, but that is something that we do see is genetics that play a role. So, in children who don't have a history where the parents were bedwetting when they were younger, they have about a 15% chance to bedwet themselves. In children who has one parent who had a history of bedwetting, that rises up to 44%. And if both parents had a history of bedwetting, that rises to 77%. So that is quite a rise in that genetic component. Now, developmental delays, as mentioned, can also have an impact. There's not specific tests to test for that necessarily in relation to bedwetting, but obviously you can test their normal milestones, and that can be addressed with therapy as well. And then in children who have ADHD, there's also a very high association with bedwetting. So they are 2.7 times more likely to bedwet than a child who does not have ADHD. With that, it is also something about tuning into your own body and being able to sense things that happens in your body and responding appropriately for that. So for that, it's very important that they go and see occupational therapists or physiotherapists who work with sensory integration to just help them sense their body signals a bit more and then respond to the body signals that they actually get. Then psychological problems is something that is very often blamed for bedwetting, and in some cases it does happen. So if there was trauma, if they are experiencing grief, if there's major life changes that happens, it can actually have an emotional or psychological impact, which can then cause bedwetting problems. But a lot of the times, the things that's thought to be a psychological trigger is also something that is a routine changing thing, like getting a new sibling or changing to a new school or a parent's split up where the child all of a sudden has to share time between two households. And I think, or in the physio world, it's often thought that the routine changes is actually the contributing factor, not so much necessarily that psychological impact of the change that's happened. Then we see that improper toilet training can also lead to bedwetting problems. So, abuse during toilet training, or people just not knowing what to do necessarily and handling it in an incorrect way, or toilet training too soon, so that these children become like expert holders and things like that, can also have an impact. Often it is also related to something that we see as the biggest cause, and that's constipation. Now, constipation has many different meanings for many different people. So I don't necessarily like referring to the type of constipation that we're dealing with as constipation necessarily. It's more these children not emptying their bowels properly, so that that space that we need for the bladder is actually big enough. And we'll talk a bit about how constipation or how not emptying your bowels properly can lead to bedwetting. Then the last thing that we often see as a cause is what they take in. So foods and drinking fluids. So often food intolerances can have an effect. And one of the biggest ones that I've seen clinically have an effect is dairy. So if there's any doubt whether a child has a dairy intolerance or a dairy allergy, it is probably a good idea to eliminate dairy completely and then monitor the effect of that. Dairy isn't the only thing that can have an impact. There's other food groups or specific types of things that you eat or drink that can also lead to bedwetting. So things that increase the production of urine, so caffeine or drinking before bedtime, can obviously have an effect. And then something like dandelion tea that has a diuretic effect can also cause bedwetting. Most important to remember with children who struggle with bedwetting is that it's no one's fault. It's not the parents' fault. It's not their siblings' fault. It's not the child's own fault. It's not a choice. So no child chooses to go to bed and then wet the bed. It's not something that's part of our natural behavior as humans. It's not under their control. So, like I've mentioned, is that bedwetting is an involuntary response that happens. So it's not something that they choose or have control over. And we know that punishment doesn't work. So, because it's not a behavioral choice, it's something that does not respond to punishments. Now, often things that parents do, they do out of, concern, and it's things that people have said, oh, this has worked for my child. And it's often not considered as a punishment, but something like making the child wash their own bed sheets can actually be seen as a punishment. Now, it's not necessarily bad to give them a task to do, but to use it as a mechanism to try and get them to not bedwet is not a very good solution. So, if punishment doesn't work, then what sort of treatment options should we be looking at, and what does generally work? So, obviously, depending on the cause, you would need to decide on the treatment available. So there are certain medications. So obviously, if there's an infection, that would need a medication to sort out the infection. If they're not producing enough antidiuretic hormone, there is a medication that can go on to actually simulate the effects of those hormones and then, make them produce less urine during the night. But they need to be closely monitored while they're on that medication because it can have an effect on their kidneys. Obviously, if they're diabetic, they will need medication to manage that. There's also all sorts of bedwetting alarms that work by waking children up and then helping with that sleep cycles and sleep responsiveness of what's happening in their body to help them wake at the appropriate times to then eventually train their bladders. And in some cases, that can be very effective. With sleep apnea, what I forgot to mention is that a lot of children with enlarged tonsils or adenoids can actually have sleep apnea problems. And so for them, surgery would be a solution. And there are children who snore and then have bedwetting, and it ends up being a tonsil and adenoid problem where that's enlarged, causing the sleep apnea and then causing the bedwetting. And in those cases, having them removed have actually solved their bedwetting. That's usually not a first line treatment, but something to definitely be aware of and take into consideration, especially if a child has a history of snoring. Obviously, we want to address the sensory components that we talked about to make them a little bit more in tune with what's happening inside their bodies and how to respond appropriately to their body signals. And then the biggest thing, and it's often the most difficult thing, is lifestyle changes. So, for a lot of things, what we eat, what we drink, how much we're moving, and then how we're getting whatever we've eaten or drunk out of our bodies in an appropriate way at appropriate times actually changes a lot. So with lifestyle changes, it's usually not big lifestyle changes that's necessary. It's small, easy things that needs to be done, but they need to be done consistently. And that is where pelvic physios come in, is to help look at those lifestyle changes that needs to happen. So we want to treat a child holistically. We want to know what they're putting inside their mouths that form their urine, that form their stools, and what they're getting out, how much they're getting out, and when they're getting out, and if they're getting it out completely. With these children, you also do want to evaluate their spines and their nervous system and their blood pressure, because all of that can have an effect on how their body responds. If there's a problem with their nervous system and there's actually not communication happening, that can actually be a bigger problem, not just for bedwetting, but for other developmental things as well. So, as I've mentioned, most commonly what we see as pelvic floor physios is that these children are not pooing well and they end up with constipation problems. Now, if you want to know how the bladder can actually be affected with them not pooing well enough, then you have to have a little bit of knowledge about what's happening in that pelvic space. So the way I generally explain it is that that pelvic space is like a bowl. Now, if you're looking at a bowl, so their bones would be the pelvic bowl that creates that space for the organs to lie in. Now, the bones are very rigid and they don't expand and move as things change. They do grow bigger over time, so that pelvic space does deepen and does get bigger. And that is why about 15% of children outgrow bedwetting problems, is because this space actually does get bigger and then their bladders can hold more volumes. Now, if you look at the organs that go inside the bowl, you look at, for example, the rectum. So imagine that's where poo comes through to go outside the body. And then you've got your bladder. So that's where pee comes into that pelvic space and then exits through to the outside. Now, that space only being so big allows a certain amount of things to be inside before things go wrong. If we are not getting rid of that inside organ, whatever fills that space, that eventually has an impact on each other because it presses onto the bones. Now, the way I generally have people think about it is if we had to fill a cup with pee and the exact same size cup with poo, and you weigh the two, what would weigh a little bit more? And obviously, thinking about poo being a solid and pee being a fluid, poo would weigh more than pee. So if something had to give, then the thing that has fluid in will actually be the one that comes second. So imagine this is full of poo, this is full of pee. If we only have that amount of space, that's going to push into the bladder. So that is why if they do not get rid of that poo properly, that poo builds up in that space and that eventually pushes into the bladder. And the bladder then often has little like hiccup contractions, which then forces out the pee that's sitting in the bladder. And sometimes that happens during the night when they're sleeping, and that then leads to them wetting the bed. So a very easy way to remember is just that bowl, the bony bit, is very rigid. It only allows so much things to come into that space before things go haywire. Poo that fills that space will be a little bit more heavy. And if pee comes in and we're not getting rid of that poo, the poo, pushes into the pee and that splurts out. So we actually need to get them to poo properly and get rid of all of that poo and not just some of it. So just a couple of easy tips to help them poo is things like getting in enough fiber. So for children, we want them to have 5 fruits and veggies a day, as big as their hand palm. So the only fruit that's not so great for that is bananas, because that can actually constipate them more. But all other fruits and veggies generally is good to get that fiber that they need. If they've got enough fiber, it bulks up the poo, and that bulkiness tells the body when it arrives and when it's time to exit. We, however, don't want it to be just bulky or hard. We want it to be nice and soft so that it can come out easily as well. And to soften it, we want them to have enough water so that it's easier to pass. Something else that's helpful is if they are active. So we want them moving, we want them playing physically, we want them doing sports and specific movements where they're going to breathe a little bit deeper, they're going to rotate in their bodies to get their bowels moving nicely. So we generally have a look at how they are moving, if they're nice and strong in their cores, and give them exercises and movements to do for that. Then we can tap into our body's natural routine to try and get it into a regular pattern of getting rid of that poo. We all have a normal reflex that's supposed to happen under normal circumstances about 10 to 30 minutes after we've eaten, so that our brains can get the message that new food is coming in. So we need to go and make space for that food to eventually become a poo that we need to get out. And then the last thing is tummy massage. So I've got a lovely video on YouTube that shows you exactly how to do a tummy massage. And that's something generally that we teach in the clinic to parents, or if the children are old enough to do it themselves, to them as well. So there isn't much time left, but we have had a couple of questions. So the first question is, my 4-year-old has been dry during the day since she was 2 years old, but she still wakes up from time to time with a wet nappy. When should we start removing the nappies? So if she's 4 and she's been dry during the day since the age of 2 already, then she's well past that 10 months of expected developmental time. We usually, if we're transitioning to being without nighttime nappies, we want to look at a consistent period over like 14 days without waking up with a wet nappy before we get rid of the nappies. We, however, want them to poo properly, preferably every day, and nice soft poos where they don't have to sit and push to get that poos out. We want to make sure that they are, taking enough fluids, getting in what they need to get in, and then getting out what they need to get out before leaving the nappies completely. Okay, I hope that answers your question. Then the next one is, my 7-year-old boy does not have any bedwetting incidences when he is with me, but when he has a sleepover at his dad's, he will sometimes struggle with bedwetting. Is that due to him being anxious about being at his dad's? Now, this is one of those cases where it could be a psychological or emotional trigger, but it could again also be related to his routine that he has at his dad's place. So they might be drinking Milo or hot chocolate or something like that at his dad's place that he wouldn't normally have when he's at your place. So that would be my first starting point, is to look at if there's any changes in his routine. Is he drinking something differently? Is he eating differently? Is he as active as he is at your place, or is he going there and just sitting and playing PlayStation or things like that? And does he do his poos at his dad's house? Because some people will only poo when they're in their own familiar environment. That would be my starting point to look at that. But keeping in the back of the mind that there could be some sort of an emotional trigger as well. Okay, that is all we've got time for tonight. Thank you so much for joining me. And if you have any questions, you are welcome to send me an email. Or if you would like to come see me in the clinic, you can go onto the website of PhysioDirect and go onto the Book Now tab for the Nongatawa Clinic, and I'll be happy to see you there. Bye.